Welcome back, everybody. So, Mitchell, you can introduce what our channel is about before we get into the topic.
Yeah, so our channel is for anybody who's new listening to this is Getting.md. We talk about everything um medical related. A little bit of everything. Mostly we're gonna focus on our road to getting into medical school right now. We're both starting to try to get into medical school. So yeah, check us out.
Yeah. So, I know this is not how our videos usually start. We usually have a title slide. So, last video was about ESBL-E infections, the updated guidelines. This is a continuation of this, so this is still part of the guidelines, just like some of the more off the wall type things. So, as you mentioned before, ESBL-Es is kind of like an enzyme that inhibits penicillins and cephalosporins and zoosin. Now, I talked about that one trial. Mitchell, do you remember what it was about with
The
zoosin?
the previous trial that was killing a lot of people that were receiving the medicine Sozin.
Yeah, exactly. So 9% more people died on Zosyn than carbapenem. So they stopped
Yeah.
the trial early. Again, I'm only repeating that because that trial was vital to people changing the medicine and guidelines being changed.
And you can check out that we summarized a little bit of the trial on the previous video.
Yeah, previous video, and there's also a citation at the bottom of videos too. I know we don't cite stuff for our videos because not as professional, but
Because we should.
probably should. But the citation is on the bottom of the screen. These are actually studies. You can go back and read them and learn for yourself. So that said, let's go into the clinical questions. So look at this question, Mitchell. You notice what it's about?
Oh, is there a role for Sosin in the treatment?
Yeah, so Zosin's role. What do you think, Mitchell? Do you think it has a role?
Yeah, no,
No. So as we talked about that previous study, that
really
really
bad.
should be cited. The guidelines should have cited that study for this question. They should have been like, you know what, bro? No, don't use Zosin. It caused more death. Bad. Don't use Zosin. Done. Next slide. So, is there a role for cefepime in the treatment of infections caused by ESBL-E when susceptibility of cefepime is demonstrated? So this is a mouthful. So cefepime is a medication. It's a cephalosporin. It's a more expensive cephalosporin because it's newer. So susceptibility. You know what that means in antibiotics, Mitchell?
No, please explain.
Yeah, sure. So you get a blood culture. You probably know all about blood cultures because I don't really know how they're done, to be honest.
Oh, yeah, yes, I do.
So you take the blood culture, it goes to the lab, and they'll run it against different antibiotics. So we did that in microbiology, Mitchell, actually, same class.
Yeah,
And so they run a chart. It'll tell you what antibiotics work against it. So there'll be an S, an I, and an R. So an S means it works pretty good, an I means it kind of works, and R means it's resistant. So if your culture comes back and cefepime, and it says cefepime is susceptible, bacteria is susceptible to cefepime, do you use cefepime instead of a carbapenem or Bactrim or whatever? Do you?
no,
No. Because still that same class. It's still in that same class of penicillins and stuff where it still can be affected by the ESBL-E, the enzyme it secretes. And here's another trial. Again, when you do more professional presentations like this, you always want to have evidence backing up like multiple trials. Because I'll be giving this presentation tomorrow to multiple doctors and pretty much entire pharmacy staff. So you have cefepime therapy for cefepime susceptibility, extended spectrum beta lactamase producing enterobacterias. You have a cohort of 63 patients, receiving empiric cefepime before transitioning to a different therapy. So 41% of the patients died, while 20% of the patients in the carbapenem group died. That's bad, right?
it's really bad.
That's double. 20, 41%, you know. So since that was so bad, they're not recommending it. So as I talked about before, inferiority trials mean to try to see if a drug like cefepime works the same as something like a carbapenem, or in this case, yeah, carbapenem. And it failed the test, as you can see. Good thing it was a small trial, once again. But still, this patient's died. We learned from it. We don't recommend it anymore. So what are the preferred antibiotics in treatment of infections caused by E. coli, Kleb pneumonia, Klebsiella, Proteus mirabilis that are not susceptible to ceftriaxone if the confirmatory phenotypic test is negative? You go by your susceptibility testing results. Again, we just explained that, so whatever your test results say, you use. Pretty much. And a nice little summary chart for you guys, since this was a complex topic from the previous video. So uncomplicated cystitis, macrobid, Bactrim, pyelonephritis, complicated urinary tract infections, carbapenem, levaquin, Cipro, Bactrim. Outside urinary tracts like a bloodstream infection, carbapenem. And anything else when it's negative, ESBL-E test is negative, you go by your results. So, Mitchell, I'm going to have you read this case to everyone. So, are you ready?
Yeah, so the background is a 44-year-old woman, height 64, weight 73 kilograms. Presents with weakness, short of breath, and increased sputum production. Her medical history is significant for HTN, diabetes, and COPD, and breast cancer, for which she is actively receiving chemo.
So, HTN is hypertension, just to make sure everyone's aware. I just use abbreviations because it's easier. But,
Yes,
so,
and COPD is chronic obstructive pulmonary disease.
yes. So, it makes it hard to breathe. That's why she's probably short of breath, too. So, tell them about the next slide, too.
So the patient's allergy includes penicillin. She's reported hives and rash. Chest radiography reveals right lower lobe infiltrate suggestive pneumonia. Blood cultures have been obtained, and the patient is admitted to the hospital, initiated on vancomycin intravenously, 1250 milligrams every 24 hours, and meropenem intravenously, 1 gram every 8 hours.
Yeah, so, again, they don't know what they're treating yet. So, that's why they got blood cultures and waiting to figure out what's going on. So, vancomycin covers gram-positive pretty well. And meropenem as it covers the carbapenem. So, it's broad spectrum. It's a very broad spectrum. It covers ESBL-E. Remember that. It covers ESBL-E. So, what's the cultures, Mitchell?
So blood cultures show Klebsiella pneumoniae. ESLB is positive. That is a cephalosporin resistant. And you reconcile her allergy and find out that it occurred when she was a child. And you successfully delabeled this patient's allergy.
So, Mitchell, do you know much about like penicillin allergies and stuff?
Penicillin use?
Like allergies, like dinner. Like, do you know much about like allergies to penicillin and stuff like that?
No, please teach me.
Yeah. So, if you have an allergy as a kid, it's probably not a true allergy. A lot of patients, like myself, say they have an allergy maybe to amoxicillin, when in reality that wasn't really an allergy. It was just like something just occurred randomly. So, if something happened, so if you know you had the allergy while you're a kid, it might not be a true allergy. There's a very high chance it's not a true allergy. So you probably need to figure that out because that cuts down on a lot of treatment options you can use. So
You
what
should
was her
probably do an
allergy
allergy
again?
test, right?
Her allergy was penicillin.
Yes.
So if in a hospital setting, if you have a penicillin allergy, you know what else that cuts you out when using?
I forget the name of the other medicine, but yeah.
Cephalosporins.
Yeah.
It's a 2% chance, but doctors are still afraid of it, so they won't use it. And piperacillin-tazobactam, so that's Zosyn. So an allergy really cuts you out of an entire class of medications.
So now you only have Sosin to give.
The Zosyn you're allergic to too.
Oh.
That's a
Oh.
penicillin.
Okay.
So now you're stuck with like fluoroquinolines, carbapenems. Anyways, this
But wouldn't
person's
be a carbapenem,
allergies.
would it be better?
Yeah, yeah.
What would you give?
We'll go to the rest of the case and we'll find out.
Okay.
So, again, you delabeled her allergy. That means she's no longer allergic to penicillins. Keep that in mind when we go to the next part. She's already on Vanc and Marum. So what do? You can read the treatment options to me, then you can decide what you want to do.
Discontinue vancomycin and continue meropenem? Continue vancomycin. Huh. I will continue vancomycin and meropenem.
That's C. Is that your final answer?
Yeah, I guess.
So C is wrong.
Well, darn.
So I'll just go through the options real quick. So A, discontinued vanc and meropenem, initiate levofloxacin. That's stupid. Okay. So carbapenems cover ESBL-E, correct?
Yes.
So why are you discontinuing merum and then starting levofloxacin for a
Well, I
Klebsiella?
didn't discontinue anything. I was thinking about continuing vancomycin and
Yeah,
meropenem.
sure. I mean, you do that,
Wait,
but
so the right answer is continuing meropenem and change vancomycin to
no, that's
cefepime?
wrong. I was going through the ones that are wrong, all of them at once.
Oh, okay.
So A is
Yeah.
wrong.
Okay.
Discontinuing vanc is correct. Discontinuing vanc and meropenem is incorrect. So
Ah.
continuing vanc and meropenem is incorrect. So vancomycin is the only gram-positive coverage. I'm gonna go back a slide so people can see. So the blood culture shows Klebsiella. Okay.
Yeah.
So using vanc and meropenem at first before you do cultures, that's cool. That's really fun. You're covering gram-positives and you're covering gram-negatives. That's good. But you know it's a Klebsiella, which is gram-negative. You don't need vanc anymore. Get that out of there. Get away. No, don't need that. So then D is changing meropenem. Continue meropenem and change vanc to 1,000. Why? I mean, that's like a terrible cephalosporin to use anyways, and merum covers everything you need to cover. So the correct answer is B. It's continuing vanc and continue meropenem. So it's a ESBL-E infection. It's outside the urinary tract. Carbapenem's first line of choice for this. And there you go. So that's it for this topic. Do you have any questions, Mitchell, or do you think they're gonna have any questions about this they can anticipate?
Yeah.
I know.
I wish I knew a little bit more about farm, but this was cool. I like
Yeah,
doing little. We should do more of this. Anyways,
yeah.
but yeah, this was
Get more presentations, you know.
yeah.
So I hope to see you guys' comments on these two videos because that's complex. I know I did not touch the basics of bacterial resistance yet on this channel, which we kind of need to do eventually, but we'll do that sometime soon. So I'll see you next time. Peace.